Ya.
Aduh. Ah. Yo. Oh, yo. Yo.
Semua dah masuk ke? Kenapa hilang? Hello? Lee,
Ya, ya, ya.
mana dalam waiting room kosong?
Ada ni.
Oh, lupa. Saya tak jadi host, saya tak nampak.
Siapa yang jadikan host?
Host sekarang Yung dia tengah buat go live. Saya tak jadi host. So sebab tu saya tak nampak.
Ni apa ni? Kami lupa lah kena pergi meeting spec pula. Aduh.
Jadikan saya
betul.
co-host je.
Ha? Aduh.
Hello?
Dia, saya kata, pegawai penerima saja boleh ambil barang.
Oh iyalah memanglah saya dulu pun penerima sebelah.
Dia kata kalau ada orang produksi pun tak apa. Orang tu tunggu kat atas store.
Saya masih lagi ke?
Orang tu tunggu solution tu.
Okey, Cik Karti dah masuk. Cuba on mic Cik Karti. On mic.
Encik boleh dengar ke
Okey,
suara
dengar.
saya?
Cuba
Okey.
share slide.
Share slide. Sebentar ya.
Which slide you want to share?
Random it.
Buka kamera, buka kamera.
First வந்து
PowerPoint, berarti which one? This one.
Moderator lah. Masa ada second. First yang satu lagi.
Maybe you mute first.
Kak Ju nanti minta jadi tolong admit nanti Kak Ju ah.
Boleh, boleh.
Saya jadikan Kak Ju co-host, nanti tolong manage je ah. Cik Karti tolong share slide.
Dia sebab tua dia tahu. Tu je. Tak makan lagi.
Minta tolong mute mic yang tak berkenaan. Okay.
Aku tidur dulu tadi. Ni dia beli juga makan. Ni tinggal sikit je.
Halo?
Hello,
Cik.
yes.
Boleh tengok tak slide saya?
Nampak.
Dia tim.
Okay. Saya ada 2 slide sebenarnya.
Dia masalah tadi. Tak buka.
Saya mute nanti buka balik ya. Saya mute all dulu, nanti on mic balik ya. Cik Kartik on balik mic.
Mana?
Okey. Nampak.
Mana slide putih?
Kita boleh mula ke Cik Kartik? Boleh mula ke?
Salah.
Cik Kartik dah okey ke?
Desktop.
Boleh mula ke?
Boleh mula?
Okey ya. Dah buka tiga dah. Okey, Assalamualaikum dan selamat petang. Terima kasih kepada semua rakan-rakan JTMP untuk hadir ke webinar sesi Mei 2025 Anjuran Kesatuan Kebangsaan Juru Teknologi Maklumat Perubatan. Untuk pengetahuan semua, hari ini moderator kita adalah Encik Izwan dari KK Langkap Perak. Beliau merupakan calon bendahari untuk sesi 2025-2027. Dan penceramah kita hari ini adalah Encik Karthigesu. Seterusnya saya serahkan webinar kita pada hari ini kepada Encik Muhammad Khairul Izwan bin Kamarudin. Dipersilakan. Silakan.
Assalamualaikum dan Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Okay. Yang berusaha KP JTMP Puan Nur Azmah binti Wan Saleh, Presiden Kelab KK JTMP Encik Hamzah bin Muhammad, yang dihormati Ketua-Ketua Bidang Barisan Esko Kelab KK JTMP, penceramah jemputan yang dihormati rakan-rakan sejorongan JTMP, para peserta webinar yang budiman. Saya Muhammad Izwan bin Kamarudin, moderator moderator pada hari inilah. Saya daripada Klinik Kesihatan Langkap. Terlebih dahulu saya ingin merakamkan setinggi-tinggi penghargaan kepada semua pihak yang hadir dan menyokong penganjuran sesi ilmiah ini. Kehadiran tuan-puan amat kami hargai dan semoga perkongsian hari ini memberi manfaat serta ilmu yang berguna kepada kita semua. Okey. Dengan seperti itu, saya ingin memperkenalkan penceramah kita pada hari ini, iaitu Encik Karthigesu Muniandy, seorang guru teknologi pengobatan yang sangat pengalaman, kini bertugas di Hospital Kelantan. Okey, beliau memulakan kerjaya di Hospital Kelantan pada tahun 2012 sehingga sekarang masih berkhidmat masih berkhidmat di Hospital Pulau Pinang, unit hematologi lah. Okey. Sebelum kita mulakan sesi pembentangan beberapa peringatan, sila pastikan mikrofon dalam keadaan mute. Soalan boleh ditulis di ruang chat yang sediakan. Webinar ini direkam untuk dirujukan pada masa hadapan. Tanpa melengahkan masa, saya menjemput Encik Karthigesu Muniandy untuk memulakan pembentangan beliau yang bertajuk FBC Validation and Review. Dipersilakan.
Terlebih dahulu saya ingin mengucapkan terima kasih kepada moderator Encik Muhammad Khairul Izwan bin Kamarudin yang bertugas sebagai JTMP U5 di Klinik Kesihatan Lengkap. Yang berbahagia Ketua Profession Puan Wan Nur Azma binti Wan Saleh, yang berusaha Presiden KK JTMP Encik Hamzah bin Muhammad, Ketua-Ketua Bidang Negeri, Barisan Exco KK JTMP dan rakan-rakan JTMP yang bertugas dengan gigihnya di seluruh Malaysia. Saya ucapkan salam Malaysia Madani dan salam perpaduan dan Vanakkam. Okay. Seperti yang diperkenalkan diri saya tu, saya bertugas lebih 12 tahun di unit Haematology Hospital Pulau Pinang. Saya boleh katakan saya masih belajar lah walaupun saya dah 12 tahun ke atas kerja di sini. Jadi izinkan saya menggunakan bahasa Inggeris kali ini dalam webinar KKJTMP sesi 2023-2025 yang bertajuk Ensuring Accuracy in Hematology, Validation and Criteria for Full Blood Count Slide Review. Okay. FBC validation, super fast but also can be super wrong. Selalunya kalau kita validate, it can be wrong. Let's see where it can be and what later on in the presentation. Mostly inaccurate or wrong results, validator will hunt us after a few. One from clinical side complain about the results to our unit or department head. And we are clueless what mistake we did during that time because it's done few days ago or maybe few months ago. Okay, the content of my presentation is today principle of hematology analysis, validation process, case examples, challenges that we faces during validation, summary or takeaway message. Principle of hematology analyzer. Understanding principle and method of the test is going to take us to the next level of producing a quality job in our workplace. We also need to understand the flagging and messages generated from the analyzer. Measurement principle of the hematology analyzer, a bit on the principles. So for the colorimetric method, we are measured hemoglobin levels. And these are the formula that the hemoglobin equals to constant time log 10 times with blank photocurrent divided by sample photocurrent. And the sample in the hemoglobin channel act as a light absorbing substance. After being treated with concentration can be measured by measuring the absorbance. And then for the impedance method are used for the cell counting. The direct current resistance between electrodes charges the blood cells suspended in the diluent which pass through the aperture. This resistance causes an electrical pulse change proportional to the size of red blood cell. So as you can see here, the bell-shaped curve is histogram of platelet histogram, and then the red color one is red cell histogram. So we should have a peak which is a definitive peak. For example, measurement which is from 2 to 30 femtoliter usually will have a normal histogram. And then for the red blood cell, which is measured from 25 to 250 femtoliter, will have a bit sharp, but it will most to the left or right side of the chart. Okay. Okay, if you can see me, if you can see the secondary sheet flow, the device here in the analyzer, it is specifically designed to prevent the recirculation of the counted cell, and it ensures the cell pass through the counting aperture in a single file. Flow cytometry technique. For WBC differential and count reticulocytes, it's based on laser lights scattering at two angles and fluorescent signals to perform complete blood count and WBC differential count. WBC are classified by size, cellular complexity, and RNA and DNA content. For the WNB, which is the WBC, NRBC, and basophil channel, differentiates basophils and nucleated red blood cell and counts WBC. Okay, as you can see in this picture, in this scattergram, we have a normal scattergram, and we have a specific area where the cells can be scattered. If it is normal, so we have a normal area where the cells can be scattered, and we also have if the cells scattered above this area which is represented by high fluorescence area or high fluorescence cells usually. Okay, and in WNB channel, the basophil will be separately measured. So we can have a view if there is a basophil present, it's in a yellow color. And then if NRBC present, then it will be in a purple. And the whole blood, the WBC and the neutrophil will be scattered here. Okay, validation process. So prior to the validation process, we receive the samples and we done demography first. So here in our HPP hematology lab, we done 100% demography before we take the sample into the analyzers. And then once the analyzer done with the estimation or done with the test, we check the sample again. And here we will concentrate on delta check or re-exam rules that are reflected by the analyzers. So one, we review if there is any flagging or abnormal parameters, we will respond to that parameters either by adding slide review or inform, if let's say it is a critical results to the respective wards or clinics. Demography. Check patient details are correct as usual, and samples with no demographic done will cause some problems. If let's say we never demo the sample first, I mean demo the patient detail first in iLab or in lab information system, the system will fail to trigger and display delta failed results in the middleware. Okay, and if let's say the first time rules trigger, right, we need to do some, we already done some extra care for the patient, for the sample, which is, we can call it high risk sample. For example, if the sample reflected with atypical lymphocyte or blast flagging, we already run slide review for this patient. We couldn't see in the system. And then we can add unnecessarily, again, we will do the same thing for the patient. So it's also unnecessary and it's a redundant patient sample. So it's not going to help anything. And the TAT also will be delayed. Sample check. Clot. Visual check on sample with flagging clumps. If there is a flagging clumps appear from the analyzer, we have to check visually, and also we have to use applicator stick to check whether there is a clot presence. Okay, reject the sample if the clot present, and perform maintenance. Example, prop cleaning maintenance for the particularly the last sample or which analyzer processed the clotted sample. We have to perform the prop cleaning. And then the volume. We also have to check for the volume. If hemoglobin or hematocrit are very low, we have to see the sample if it is diluted to exclude pre-analytical errors, such as either the blood is taken from drip site, hemopod, or arterial or vein fistula. If we found that one of these reasons that cause to the diluted sample, which is causing the diluted sample, and request the new sample. And we have to inform the doctor or the staff nurse who is responsible and ask for a repeat sample. Delta check. Comparison of laboratory test result with results obtained on previous samples from the same patient. Okay, so particularly useful for detecting errors in specimen identification. By doing this delta check, we can use, or we can, it's very useful to detect errors in specimen identification, specimen integrity, whether the sample is sent to the lab after maybe more than 2 or 3 hours. I mean, after the sample integrity is lost or the sample stability is lost. Okay, and errors in manual data entry, pre-analytical issues, or possibly analytical issues. There are quality control issues that usually cannot be detected by testing QC materials. Okay, this is the it's for me it's confusing. I hope you can stick with me. Okay, we can go from here. Okay, we check the correctness of patient detail on the sample and the system. Once it's correct, it's tally and correct, we will see if any delta check. If delta check failed or passed, if it is passed, when compared with the previous sample for the same patient, we check the message from analyzer, such as flagging for rules, scattergram, histogram, and if there is any re-examination rule. If it is normal, we validate. If it is abnormal, such as if scattered plot were noted abnormal or not well separated, automated DC in iLab should be masked. iLab here can be any lab information system that you have in your labs. Okay, we will mask the differential count. Okay, proceed to the slide review. If so, we can done a confirmation through the manual differential count. If the manual differential count is tallied with automated differential count, we will validate the automated differential count result as a final report. If the manual DC does not tally with automated DC, we validate the manual DC result as the final report. If the delta check failed, so we will check the sample for clot, volume, or diluted. This is the pre-analytical issues that usually present. If there is, we reject. We will inform the what when we do rejection. Okay, so if the analytical issues, pre-analytical issues is not presented there, which means it's not involved. So we will mix and rerun the sample in different analyzer just to compare the results. If it is tally, we will see whether there is flagging come out or not. If tally with flagging, we will respond to that flagging as I already covered here. If it is tally without flagging, we will inform and validate the results. Okay, what happens if when we run with another analyzer and it's not tally? Okay, the problem appears when it's not tally. I mean, how are we going to solve it? So it's going to give us some challenges here. Okay, we can see, re-examine all the samples from that particular batch in user. Okay, if it is not tally, we have to re-examine the old sample from the particular batch in a different analyzer. And if all the samples not tally with second run, it means the whole 10 samples, it can be 10 samples or 5 samples. So whatever the last automated method you use, the rack that you use, all the sample should be considered. If not all the sample tally with the second run, so it's going to be troubleshoot. We're going to troubleshoot the analyzer. It possibly the analyzer that having some problem. Okay. So what about here? If all the sample tally with previous and only one sample is problematic, we inform the ward and request new fresh sample. Okay, I hope you stick with me throughout all this explanation. Okay, we see the parameters involved is actually 3 important parameters: hemoglobin, WBC, and platelet. And then the deviation which is we allow is absolute from below or plus, below or more than 1 gram per deciliter. From gram per deciliter, it should be the what do we call, the delta check flag will be triggered. For whereas for the WBC, if it's relatively plus or plus minus 20% from the previous count, and for the platelet too, it is plus minus 20% from the previous count, then the delta check will be triggered. So the duration.
Alamak, kita punya penceramah terputus. Sekejap. Penceramah lost connection. Sekejap ya.
Tak apa, boleh teruskan.
Encik Karti boleh sambung? Tadi putus. Cuba test mic semula.
Boleh ke? Hello?
Okey, boleh. Besarkan slide.
Ya, boleh nampak?
Bagi full slide. Okey, disambung.
Boleh tak? Boleh tak? Sambung ya?
Boleh. Boleh sambung, tak dengar lah. Cuba share semula slide.
Okey, saya share semula.
Harap bersabar, ada masalah lain sikit.
Boleh? Saya boleh dengar?
Okay, boleh teruskan.
Okay. So this is reviewing abnormal parameters of flaggings.
Silakan slide tu boleh tak?
Okay. Then. Boleh?
Okay. Sambung.
Okay. Okay, right. So kita boleh nampak there is a 3x3 rule involved. It's involved RBC, hemoglobin, and hematocrit. Okay. Okay. So when we see here, we got our count here, RBC 0.42. In this case, we can see there is flagging come out from the machines, and then this flagging is stated here as lymphopenia, turbidity or HB interference, RBC agglutination, dimorphic population, RBC histogram, abnormal, and anisocytosis and macrocytosis. So when we concentrate here, when we see, before we validate, we have to see whether these 3x3 rules are obeyed or not. For example, RBC 0.4. It should be plus minus after roughly we times 3 plus minus should be HB. But here 0.42 is far way lower than expected. And for the hematocrit, with this HB 10.4 times 3 plus minus should be like 30 plus. Okay, but here the 3x3 rule is not obeyed. And we also can see there is a MCV 174, which is way higher than the normal. MCH is also very high, and MCHC and so on. So this one is involved with the this is because of the flagging RBC agglutination. It is due to cold agglutinins. Okay, these are the abnormal flaggings that produced almost more than 20 flags, about 20 flags from the abnormal blood cells and 14 flags for abnormal red blood morphologies. Okay, I think I'm not going to go through one by one because this one is a very general one. Okay, I would tell you what is flag. Okay, a flag is usually high or low by default, or small h or small I, or with a sign of arrow go up or go down. It's depend on which analyzer you're using. So it still flags, and the messages are either high or low results. Okay, and meaning the analyzed results exceeded an upper or lower limit of the reference range, but it's still within the displayed range. Whereas for the capital R or small r, it is suspicious flag. The analysis results is suspicious. And before validation, we have to rule out what are the suspicious things appeared here. Okay, and then this sign N is an algorithmic rectified flag. The analysis result is rectified by algorithm of the instrument. And LIS is out of the linearity range. The analysis result is out of the linearity range. And the plus signs, there is usually a 4 plus signs the message is out of the parameter results displayed range flag. And it means the analysis result is out of parameter results displayed range. And then there will be a star, 4-star here at the lower here. Its message is screened result. So the meaning is when the analyzer deem that some parameter results are not reliable, for example, the differential result of certain types of abnormal samples, the results of parameters would be screened from the report screen and display as plus sign. Sorry, the star sign. So as you can see here, this is the example of star sign, as I told you. So the analyzer couldn't give the differentiation of these matured cells because most of the WBC here may be immature cells. Okay, abnormal flagging. So these are the abnormal flaggings and the action taken. If I say the analyzer flag for WBC scattergram abnormality, we will do smear if it is a first time. WNB scattergram abnormal, we also do smear. The smear here is slide review. Turbidity or hemoglobin interference, we have to check with biochemistry for the high lipid result to confirm. Then if it is involved, if the lipid causing the 3x3 rule not obeyed, so we need to do plasma exchange. Platelet histogram abnormal, we have to do smear and to confirm the count. Platelet clumps, we need to do smear to see whether it is due to partially clot or erythema-induced platelet clump. Lipid particles, if it is disturbed the 3x3 rule or it never give accurate result for the hemoglobin, RBC and hematocrit, so we have to do plasma exchange and we have to remark on the report. Infected RBC, we have to do smear. RBC lyse resistance in the same mode, rerun with pre-dilution. If the flagging still appear, so we have to rerun in pre-dilution mode. For the reticulocyte scattergram abnormality, we need to do smear, aspiration or abnormal or clots. We perform sample check and perform maintenance as needed and rerun the sample. If the problem is still or the flagging still appear, we have to recollect the sample. RBC agglutination, we do pre-warm and we proceed to plasma exchange. Okay, these are the another examples of scattergram, which shows abnormality, which is there is no differentiation done, which is all the scattered is just mixed around and overlapped. So the flagging here is WBC scattergram abnormal, blast, atypical lymphocyte, blast or blast immature granulocyte, atypical lymphocyte, left shift, NRBC, WBC fragments, and so on. So we have to react for this flagging. And if you see here, the total void is 198. So definitely there might be some immature cells are present and we have to proceed to slide review. Then another scattergram here. So WBC scattergram abnormality, abnormal lymphoid or blast, lymphocytosis and leukocytosis. This is another examples that we need to proceed to slide review. As we can see here, the scattergram here, the all matured cells such as lymphocyte, monocytes, this area are overlapped. And the histogram here is normal. Platelet histogram also normal, provided the platelet count is normal. And this is the hemogram. In hemogram, we can see there is WBC is very high. And this lymphocyte is very high. Okay, this R sign here is the suspicious. So we have to proceed to slide review to confirm. Abnormal MCAC parameters. what we do, let's say MCAC is more than deciliter, it could be due to hemoglobin falsely increased and RBC falsely decreased. So if hemoglobin falsely increased, it is possibly due to chylemia affected, which affect the turbidimetry measurement of hemoglobin test. Similar case, high bilirubin sample. Recommended actions are plasma replacement. We replace the plasma with DS diluent, whatever diluent that you're using from any analyzer, and also normal saline also can be used. So we must ensure that the same amount of plasma replaced with the same amount of diluent. Okay. For high WBC, large number of WBC cell affects the turbidity of plasma too. Usually, if the WBC more than 40, and the turbidity HV interference flagging appear, so we have to react for that flagging. So we measure the MCAC from red blood cell and estimate hemoglobin inversely. We involve some calculation here. Okay. RBC false decrease. It could be due to RBC agglutination or RBC single counting decreases. Okay. And the action recommended is pre-warm, pre-dilution, or plasma replacement. Okay. For hemolytic sample, which also can cause the RBC to be falsely decreased, RBC largely decreased, and hemoglobin measurement might be affected. If caused by pre-analytical error, we have to reject the sample and ask for recollect the sample. Then for the MCAC, which is lesser than 29 gram per deciliter, the measuring parameter MCV will be falsely increased. And this is due to maybe retic or NRBC interference. Then we remark on the report. Okay, abnormal parameter or abnormal flagging. What to do? Few actions involved, such as rerun the sample, rerun the sample, and we react to the reflex. Either it reflex the test, which is it is auto reflex by analyzer, plasma replacement or dilution done, pre-warm sample, and lastly is smear. Okay, plasma replacement. How to tell you about plasma replacement, how it's get done in HPP. So we centrifuge the sample with 2000 RPM and about 5 minutes. Take the certain amount of plasma and replace with the same amount of saline. Okay, the certain amount of plasma denoted by half or 2/4 is not the exact formula that we use. We actually have to count with a micropipette, and extra care should be given so that we not go deep the pipette tip to the where the platelet and WBC might be settled. That is between hematocrit and also the plasma, the Buffy code. Okay, we should not reach that area because we might falsely or we might mistakenly suck out some of the WBC or platelet there. Okay, and mix well 8 to 10 times by inverting the tubes. So we repeat the step 1 to 3 as I mentioned another one time. Okay, so mix sample well and rerun the sample on analyzer. And if no improvement showed in the results, we repeat step 1 to 5. We have to redo again and rerun the corrected sample in CPC mode and replace hemoglobin, MCH, MCAC result with improved one. Whereas for the WBC platelet differential count, you can use the result that we obtain from second estimation where we done after pre-warm. That is more accurate than initial test, which is we run without any measures or any action. Okay, if plasma replace is carried out, run sample in CBC mode only. Release original or initial WBC plus platelet result because WBC and platelet may be lost during the steps. RBC related result from the plasma exchange. After each plasma exchange, please ensure that R flags removed. Either the RBC result is normalized or comply RBC hematocrit and hemoglobin, which is 3 times 3 rules. Normal RBC and histogram distribution, or RBC agglutination flagging removed. We have to make sure all these flaggings are removed or not. Okay, these are the flow chart of RBC agglutination is what I mentioned. Okay, so we move on to next. Okay, what are the critical results? Here we see if let's say the WBC is more than 50, we set that count that beyond 50 as critical result in iLab. So there will be H sign present, double H. So we have to inform. And if it is lesser than 2 times to the power of 3, also we will inform. And for the hemoglobin, for the hemoglobin adult, if it's more than 19 gram per deciliter, whereas for the neonates, if it's more than 22, and for the peds, more than 20 gram. For the lower limit, for the adult, if less than 6, for the neonates, less than 8, and for the peds, if it's less than 7. So hematocrit level, upper limit is 60, and then the lower limit is 20. Platelet more than 1000 for the upper limit, and for the lower limits less than 20 or less than 50 for the peds. Okay. So as you can see here, this is the iLab, and then we can see there is purple color highlighted here. This is due to the critical value, critical result, exit critical results. Okay, the limitation for the critical result. And then we have to inform the requester or recipient. Document the name and designation of the recipient. A recipient need to read back the result. Okay, we can ask to read back. Then make sure this is get done, because over the phone we can tell one digit and they can hear the other things. Okay, and when we ask to read back, it become funny things for us. Okay, it's really involve the listening skill, so better we tell them to read back the result. Okay, validation of slide review. Okay, once ABC validation done by lab technologist, and if let's say the ABC need to be added further test slide review, so the morphology review by lab tech and confirmation done by medical officer. And if medical officer want to get second opinion from pathologist, so they will send to pathologist, and the final result will be issued. Okay, ABC validation and criteria for slide review analyzer. Okay, criteria. This criteria we follow in HPP hematology lab. Okay, criteria for the count. Let's say first time the WBC is less than 1.0, we will add slide review. And if let's say the analyzer couldn't produce or it shows incomplete differential count, so we will mask all the differential count and we will add slide review for it. And if there is any blast, flagging, atypical lymphocyte, abnormal lymphocyte, for the first time, we will smear, do slide review. And for the IG more than 5%, we will do slide review. Abnormal scattergram, crossly or abnormal scattergram. So we will do slide review. For the red cell, if there is any flagging for fragments, RBC agglutination for the first time, we will do slide review. And then if NRBC more than 5%, we will do slide review. For the platelet, if platelet drop less than 150 with platelet clumps or abnormal platelet distribution, we will do slide review. Okay, there are some cases that we no need to do slide review, such as below here. Okay, flagging abnormal scattergram by review of scattergram shows within normal scattergram pattern with a normal ABC or hemogram. Okay, we will disregard this for the further slide review adding. Cases with slide review or peripheral blood film that has been performed within 7 days for the same patient. And ABC count indices tally with previous. Flagging platelet clump with platelet count more than 150 or less than 150. If more than 150, we never do slide review. If it is lesser than 150 with platelet clump, we will do slide review. For hemato-onco, peds oncology, and other oncology cases, to follow accordingly. Okay. Here are some of the hemato cases and the what involved. And differential count release the ABC with full DC generated by the analyzer if the DC is normal. And no slide review needed. Slide review done for manual DC only when the analyzer does not generate any DC or incomplete DC or abnormal scattergram. In doubtful cases, to confirm MO or pathologist in charge, and also you can refer to WI. Okay. These are the flaggings and slide review report and who can release the result. For example, flagging smear such as abnormal RBC agglutination fragments more than 5%, abnormal WBC, abnormal scattergram, no DC, with no flagging, which is we release the results straight away. If there is a platelet clump and the sample is clot, we reject. No DC or normal WBC, we just report. And atypical or lymphocyte, which is regardless the amount.
Minta maaf, kita punya penceramah hilang lagi. Internet dia tak stabil. Harap bersabar. Kita akan kembali.
Nampak dah ke? Sorry.
Okay, nampak. Belum nampak lagi slide. Okay.
Ya. Okay dah?
Nampak.
Okay, boleh nampak slide? Boleh?
Okay, nampak, boleh sambung.
Okay, saya sambung ya. Okay, for the MO part, which is suspicious blood cell or suspected hemolysis, we pass to MO. Cases without suspicious cells or hemolysis picture, no DC, known case with abnormal WBC IG, so it's reportable. And for the MO, which they want to refer to pathologists, they also can send to pathology double confirm if there is any blast or abnormal lymphoid cells or hemolysis present. Okay, these are the SRCP is platelet count require verification. Please await slide review report. And if let's say in slide review we noted the platelet count is verified. So it's a MLT level. If platelet clump is flagged, but also when we do smear and we that there is abnormal cells presence, so we have to react for the abnormal cells, and we also have to uh, pass the slides to MO for the review or second opinion. Okay, for the PL2, PL2A, PL2B here, this is a reporting where significant platelet clumping seen, suggestive of EDTA or EDTA-induced platelet clumping, suggests to send new sample inside treated volume. Okay, this one, as we all know, if EDTA sample is collected, usually certain patients they will have platelet clumps. But once they do the sampling in a citrated tube, then the count back to normal. Okay, this is the level of MLT to validate. But if there is a presence of significant platelet clumps, we also can we can put a remark on that. Okay, for the SRCP, if partially clotted sample, there is a comment that we give is partially clotted sample suggests to repeat test in EDTA tubes. Please ensure proper sample collection with adequate mixing specimen. And the validation level is MLT. And presence of fibrin clot or stents without platelet clumps. That's going to be the remarks. Okay. For the SRCD, which is for the differential count, the differential count require verification. Please await slide review report. So the reporting is that the WBC differential count is verified and it's an MLT level. We can validate the sample. We can validate the slide review. If let's say manual differential count is tally with analyzer, so we'll follow the analyzer differential count. If let's say it's not tally, we will finalize the slide review findings for the differential count. And if there is no abnormal cells present, MLT can validate. Okay. If there is atypical reactive lymphocyte, may confirm with MO or pathologist first if in doubts. And if let's say the manual differential count is abnormal, we can pass to MO, medical officer, as a second opinion. Okay, for the SRCM morphology, this ABC require morphological verification, and there is a comment. Please await slide review report. Okay, so the reporting going to be no morphological abnormalities, atypical lymphocyte seen. This ABC require morphological and interpretative report. The test is converted to ABP. Please send new request form with relevant clinical history. They're going to be the remark on the report, or they're going to be okay. So the level of validation is MO or pathologist. Okay, no MLT involved. Okay, case examples. Okay. So as I told you, 3x3 rule is not obeyed here. RBC, HB, hematocrit, which involves these three parameters. And the flags is turbidity, HB interference, RBC agglutination, and anemia. Okay, so as you all know, by now, you all should, I hope that the viewers know, the audience know how to handle the case, like which to exclude and which step to follow to exclude this interference, which is agglutination. Okay, this is the corrective action done, and after corrected, hello, boleh dengar ke? Hello. Okay, after So correction done, you can see the count is back to normalize. So the 3-time rule is here obeyed. And even the flagging is disappeared already. So we can validate these samples. Okay, these are smear, warm sample and plasma exchange done 3 times. So these are the initial results, and on the right is the final results, which is the flagging was ruled out and the corrective action was taken. So the RBC agglutination is due to cold IHA present in the blood. So this is the morphology findings for that particular patients, which is you can see the RBC is agglutinated. Okay, case 2, anemia or thalassemia diagnosis. So we can see platelet I, platelet impedance was 847. So look at this platelet histogram. There is no definitive peak here. To the side, which is usually shouldn't be here. Okay, this is not a true platelet histogram. Okay, when we see the RBC is quite okay, so we can check. So this platelet value is from the impedance method. Okay, and then flagging is RBC analysis abnormal, anisocytosis or microcytosis. So possibly the microcyte, which is the smaller red cells present, that is causing the platelet histogram to be abnormally displayed here from the analyzer. Okay, now this is the second run. After we done reticulocytosis, adding reticulocytosis count, and also we got platelet, which is improved platelet 304. Okay, and then there is still not much improvement on the histogram. Okay, so fragments was appeared. There is some fragments. And as you can see, the diagnosis also about anemia or thalassemia. So it's suspected that this patient might be a thalassemic patient. Okay, then slide review need to be done to confirm for the platelet 2 for this patient. And this slide review can be converted later on to PBF. Okay, this is hemoglobinopathy. Okay, this is the morphological finding of the patient just now. So you can see a lot of fragmented cells. Okay, target cells, elliptocytes. Okay, polychromatic cells are here. Bite cells or helmet shapes also presented. Okay. Case 3, infected RBC. Okay. What is infected RBC? If RBC infected by some parasites, yeah, there is. Okay, you can see this is a rare case that not most of the Malaysian has, but foreigners, yes. If you're having a foreigner blood and these flaggings came out, too many artifact, RBC light resistant, WBC scattergram abnormal, WNB scattergram abnormal, and immature gland, left shift, and most important, infected RBC. Do not disregard this flag. Okay, as you can, not much to see in the scattergram or even the RBC histogram. If you never see the last flagging here, infected RBC, you would miss this case. Okay, and even in the WBC here, most of the parameters appear with R flagging, which is could not be the true value. Okay, this is a suspicious value. So we have to do slide review. So these images is actually from MCAT. Okay, MCAT is an analyzer which is automated blood morphology machines that still under evaluation so far. So this we run that sample in this analyzer, and then we found out that this is not the trophozoites of malarial parasites or what. This is the platelet. Okay, this is just the platelet. Okay. Okay, if you can see the red cell here, all the red cells are very nice. And tada, here you can see the ring-shaped trophozoite. Okay, there is chromatin here, single chromatin. Okay, and these are platelets. Okay, these are gametocytes. Okay, this is not giant platelet. These are gametocytes. Okay, giant platelet. Don't get confused with giant platelet. Okay, so the size is almost about a red cell or bigger than red cell. Then you can see a lot of what do you call it? The gametes inside, ready to be burst and infect other RBCs. Okay, immediately report to the MO or pathologist. Okay, slide review monitoring for hematomalignancy cases. Okay, these are the data. Okay, for more accurate look, we detected almost 13 cases in 2019, 8 on 2020, and 21 about 12, and the following year 13, 2023 about 13, and last year was 9. So this is all from slide review screening. Okay, MPN about 2 in 2019, 2022, 2020 is 4, and then last year was 3. Okay, so these are the total cases, positive cases that we detected through slide review, performing a slide review. So number of FBC received is 248,865, and the number of slide review was 9,000. Okay, detection rate is 0.2. Then I would say we still below performing. Okay, by right we should perform 10% slide review from total sample received, and we are still doing our best to reach that target. Okay, slide review monitoring for hematomalignancy cases 2024. Okay, these are the location and a number of cases from ED, from C8, PHTU, and ICU, clinic, and NW, C, ED, most number of cases, 10 cases. Okay, okay. Okay, challenges that we face is lack of skills, practice, and education. Okay, when there is a lack of skill present, which we couldn't perform well, and then we can miss some of the important flaggings that we have to react to, or we have to do further test to be added, like slide review. Okay, lack of experience, and lack of experience is due to the maybe working for a few years, and we less frequently exposed to the validation, and then that is the possible reason for the lack of experience. And also, if there is any new findings on they detect new cases, and we don't have interest to know what case is that, and what is the findings, what is the final report. Okay, should have we have to concern on patients' results. So we have to really get to know what is the final result for these high risk samples. Okay, lack of experts or guidance. State hematologists or state pathologists, others around. Okay, so it's been maybe you're from KK and you're from some district hospitals. So lack of experts present at the working environment or the lab. also can be cause this expert guidance are missing, okay, and then the chances for our knowledge to grow is also less. So uh, to overcome that, I think we have to conduct some trainings for slide review and morphological review state-wise, if there is any possibility, and we done that frequently. Okay, lack of confidence, time, and with patience. Okay, lack of confidence also can be cause. Sometimes we are not confident and we just want to validate without any further action taken. Okay, and we also never consult with any senior MLT around, so that's the challenges. Okay, too much work, sorry, too much work, yeah, that's unavoidable. I think daily we receive a lot of samples, no matter you're from KK or you're from hospitals, but when we concentrate one at a time, we should face these challenges. Okay, no matter how many we received and we run, we validate.
Minta maaf, kita hilang lagi connection. Kita harap Cik Karti akan kembali. Lupa topak kot. Puan Mazatul, Cik Karti ada kat situ ke?
Ada lagi. Minta maaf lah lain. Tak apa-apa elok ni.
Okay, sementara kita tunggu Cik Karti masuk balik, boleh isi kehadiran dulu. Link kehadiran telah dikongsi di chat box.
Cik Kartik masuk.
Okey, Cik Kartik boleh continue. Kita dah running masa dah ni. Tak dengar lah, boleh buka mic Cik Kartik.
Okay, sorry, maaf ya, technical problem. Okay, summary. As a summary, I would tell you we should understand our analyzer to the maximum level. Okay, in case we not understand, then we're not gonna use correctly, or we maybe miss some of the flagging that appear. So if we need a help, we can ask always for the vendors to conduct a training session. So if can, throughout the year, 2 or 3 times is better. Okay. And we should establish a local protocol for WBC validation as well. And we need to respect the flags and messages such as rerun, repeat, morphology review, plasma exchange, etc. Okay, we have to react for this flaggings. Okay, we have to continuous education and practice. And last, we should see that is our result safe for the patient? Does it help patient improvement? Okay. With this, I end my presentation. Thank you so much for everyone for your patience and to listen. Okay, spend your time to listen to me with all the challenges like connection error and all. Okay, sorry. So maybe next time we can get a good one. Okay, for you. Thank you so much.
Hello. Okey. Terima kasih kepada Encik Kartik. Okey, Cik Kartik, kita ada soalan tentang FBC. Soalan dia, FBC agglutination nak pre-warm atau ada masa tak? Okey, soalan yang pertama.
Okay. Untuk soalan pertama ini, agglutination, bila ada flagging agglutination, kita kena pre-warm sebanyak 15 minit pada 37 darjah Celsius.
Okey, soalan yang kedua, Haizat tanya, Macam mana untuk kes RBC step each other, efek RBC parameter perlu ke kita buat pre-warm juga?
Untuk kes multiple myeloma ke? Sorry,
Ya,
MM.
betul. Ah,
Okey, boleh sekali lagi bacakan soalan tu, sorry.
okey. Untuk kes RBC step each other, efek RBC parameter perlu ke kita buat pre-warm?
Tidak, kita tidak perlu pre-warm, tapi kita kena buat slide review untuk confirmkan betulkah ini multiple myeloma cases. Sebab bila kita buat slide review untuk cases macam ini, kita boleh ada satu background smearing which is warna dia lebih kurang macam pink. Kita akan ingat dia adalah lipemic sample, tapi sebenarnya dia adalah hyperproteinemia due to the multiple myeloma that produce. So RBC takkan stain well except WBC and platelet. Jadi kita proceed with slide review lah. Okay. Ada lagi soalan?
Okey. Soalan dia, KK lain untuk critical value HB inform kepada paramedik berapa ya?
Maksudnya the value ke? Value ke?
Ya, betul. Value.
Okay. Okay, kalau kami kat sini kami set below 6. Okay. Dan dia depend pada local practices lah. Kalau ada pakar ke di tempat anda, kalau mereka kata bawa 6 atau bawa 7.
Okay, soalan seterusnya, if hospital critical value for HB less than 6 and HCT less than 20 must be informed at clinician, if not result cannot to release or validate.
Yeah, prior to to validate the critical result, we need to inform. If let's say during office hour, okay, we can inform the ward or the clinic that involved. So after office hour, we have to inform, no matter it is from our local facility ataupun dekat luar, kita kena inform pada pegawai yang responsible lah. Either dia adalah doktor ke yang buat on call ke, kita kena inform.
Okay, ni Puan Salmiah. Dia sharing di hospital mereka, we apply lebih parameter selain WBC. More than 3 atau more than 30. Dan platelet less than 20 atau more than 1000 include. Lymphocyte lebih pada 5, mono lebih daripada 1.5 and eosinophil lebih pada 2 for slide morphology review. Just sharing only. So, itu je soalan kot yang kita terima. Okay.
Sebenarnya kalau kita ikut analyzer masing-masing, dia punya cutoff value pun different, dia punya threshold ataupun dia punya sensitivity pun different. So kita kena stick to the vendor suggestion and dia punya recommendation lah.
Okay. Baik, ada soalan lagi? Kalau tak ada, tak ada soalan dah setakat ni. Okay. Terima kasih kepada semua peserta yang menyertai webinar ini. Kami berharap anda mendapat manfaat daripada pembincangan hari ini. Untuk mendapat CD penyertaan, sila isi nama dan material kehadiran dan anda melalui pautan yang telah disediakan. Sekali lagi terima kasih kepada Encik Karthigesu Muniandy atas perkongsian yang sangat bermanfaat. Kami berharap dapat jumpa anda lagi sesi yang akan datang. Sekian, terima kasih.
Terima kasih.
Okay.
Jumpa
lagi. Okay, saya ada pengumuman untuk CJ penyertaan hanya akan diberikan kepada ahli KK-JTMP yang aktif saja. Namun begitu, bagi JTMP yang belum mendaftar selain ahli, anda amat dialu-alukan untuk mendaftar dan menjadi sebahagian daripada komuniti version ini. Okay, Suklab akan berlangsung di Kedah pada 27 hingga 29 Januari 2025. Acara ini menghimpun warga JTMP dari seluruh negara dalam pelbagai aktiviti ilmiah dan santai. Antara tarikan utama ialah acara fun run yang akan berlangsung dalam suasana penuh semangat dan keluargaan. Untuk maklumat pendaftaran bagi acara ini, acara fun run masih dibuka sehingga 31 Mei 2025. Lepas, okey, ada satu lagi untuk announce, kita ada KKJTMP ada buat program pemantapan JTMP Zon Timur, iaitu Pahang, Terengganu, Kelantan. Okey. Tarikh penutup penyertaan adalah 30 Jun 2025. So program ni akan dianjurkan pada 12 hari bulan 7 hingga 13 hari bulan 7 2025. Okey, ahli yang aktif pembayaran hanya RM80 dan bukan ahli 100 lah. Itu saja. Terima kasih semua.
Okey, terima kasih Cik Izwan dan Cik Karthik. Ada permintaan sebenarnya, dia orang nak tengok muka moderator dan muka penceramah. Ada yang cakap nak tak kenal penceramah. Cik Karthik dah hilang dah ke? Hilang. Okay, tak apa, terima kasih kepada semua yang hadir. Kita akan jumpa lagi insyaAllah webinar akan datang. Terima kasih turut memberi sokongan kepada program-program kesatuan yang mana belum menjadi ahli itu, sama-samalah kita mendaftar dan mendapat benefit bersama. Jangan lupa acara suklab kita, sukan kebangsaan kita di Kedah, pakat-pakat mai Kedah nanti. Berkenaan dengan keahlian, boleh berhubung dengan Esko Keahlian. Saya kongsikan lagi sekali link kehadiran, boleh isi link kehadiran. Terima kasih kerana join. KK Bandaraya Ikan, please. Anak-anak kita bukan tak aktif, cuma mereka terlupa bayar. Buat bayaran dekat portal. Kita terpaksa membagi CJ kepada ahli yang aktif sahaja sebagai benefit. Kalau tidak, tak adil kepada ahli yang buat bayaran, sebab yang diorang buat bayaran tapi yang tak jadi ahli pun dapat benefit yang sama kepada ahli. Itu tak adil lah. Okay, terima kasih, saya akan tutup ya semua. Assalamualaikum. Selamat petang.